Good afternoon. We're live.
Very good. I just want to welcome everyone to the summer meeting for the Health Policy Commission. Our group never rests. So we have a full agenda today, which will include both an extensive public session and then an executive session, as we will move forward on a number of our special activities. Before I begin, I would like to get approval for the minutes for June 24th. Is there a motion to approve?
So moved.
Okay, now, as you now know, I'm sure, because we are meeting in virtual session, we need to take the roll call for the minutes. But before I ask for the final vote, I want to make sure that if anybody has any changes or amendments to the minutes. Having heard none, is there a second to move the minutes?
Second.
Thank you so much. As in the past, I'm going to turn it over to Colleen Alstemeyer to read all our names so we can officially vote for the approval of the minutes. Colleen?
Absolutely, my pleasure. I'll start with you, Mr. Chairman.
Okay. Approve.
And Vice Chair Cohen.
Approved.
Commissioner Berwick,
Approve.
Commissioner Blakeney,
Approve.
Commissioner Cutler,
Approved.
Commissioner Foley,
Approved.
Commissioner Haupt,
Approved.
Commissioner Master Giovanni,
Approve.
Secretary Setters, approved, and Brendan Moss.
I'll abstain.
Thank you so much.
Very good. All right. So as I said, we have a full agenda. So I'm going to turn the meeting over to our Executive Director, David Sells, who will give us a more detailed discussion of the agenda and some opening remarks. So David.
Great. Thank you, Mr. Chairman. Good afternoon, commissioners and members of the public watching on YouTube. Welcome to, as the chairman said, the summer meeting of the HPC. So for today's agenda, we have both a public session, which will run about an hour and a half, and then the board will move into executive session. The board will not return to public session after we move into the executive session. So for the public portion of today's meeting, I'm going to turn over to Colleen for the executive director's report, where she'll be providing an update on some new publications that the HPC has released, and also wants to give an update to the board and to the public about our work over the past year of incorporating health equity principles into the HPC's work and mission. We're then going to have a brief presentation on some new research that we expect to release today as part of our DataPoints series, which is our online interactive data research series online. This will be on the rate of preventable dental visits that are showing up in the emergency department, an update of some work that we had done previously. And then the bulk of the public session will really shift to a conversation about the upcoming 2021 cost trends report. This is our annual report. It has been shifted in terms of the timeline this year due to the pandemic last year and shifting timelines by CHIA and some of their data collection. But we are nearing the final stages of development of the report and really would love an opportunity to hear from the board and for the board to discuss what some potential policy recommendations that we may want to include in this year's report. The report will be finalized over the next 6 weeks with the input of commissioners, and we hope to be able to release the final version of the report in September. Finally, we'll have just a quick business vote on our budget, just allowing us to continue to operate until a later budget vote this year. So with that as just an overview of today's big agenda, I will turn it over to Colleen, who will handle the executive director's report.
Thank you so much, Director Seltz. I have one slide here on new and upcoming publications. I'm going to highlight only 2 of these new items because most are on the agenda for this meeting, as David just said. So as part of the closeout process for our Mother and Infant Focused Neonatal Abstinence Syndrome Investment Program, our NAS program, we published a full evaluation report in May that is on our website. But also at the end of June, we released an anti-stigma resource guide, which is a compilation of resources curated by our NAS awardees themselves that covers how to address stigma while caring for families impacted by opioid use disorder based on lessons learned during the program. So definitely check both of those out on our website if you can. And now, as David said, we can move to the next slide. I'm going to pivot to an update on the agency's health equity agenda and implementation plan that we've been pursuing over the past year. So on this first slide here, you'll see this is very familiar to all of you. In July 2020, so a year ago, I shared with you the HPC's health equity framework and our commitment as an entire agency to using all 4 of these core strategies as we seek to address and promote health equity in the Commonwealth. So today, providing you with an update on our progress to date, requesting any feedback that you have in this meeting or offline, either way is fine. So looking for feedback. On the next slide, these are exemplar questions that guide our work when applying a health equity lens. So as part of that implementation of that framework through all the 4 core strategies, we set out to apply an equity lens at all points in a work stream or a project's life cycle. So these questions shown here were created by staff as a guide from initiation through closeout. And this past year, they've really helped us to shape new programs, helped us to modify existing work, ensuring that we're applying this equity lens and creating plans that document the specific actions we will take. Now I'm going to share with you items excerpted, apologies for that, implementation plan. I'm going to walk through these at a very high level. So please, if you have any questions or want to engage more in these details, please do let us know. And we will be providing regular updates to you at future board meetings. But on the next slide, if you will, this is our research and report strategy, one of our 4 core strategies. What a health equity lens would look like in action here, we think includes thinking about what data do we have, what data do we need, and how do we communicate our findings. So that's the core of that. Very specifically, translating our research and report objectives for implementation resulted in updates to this upcoming 2021 costings report coming out in September. It includes an explicit equity and affordability section, equity focused measures in the dashboard for ongoing tracking. And we're also committing as well to including an equity relevant topic or analysis in future cost reports. So that's just a specific example there. On the next slide, this is our partner strategy. So for this strategy, applying a health equity lens involves embedding health equity considerations throughout all of our investment programs and all of our certification standards. So developing specific procedures and tools for each stage of program and certification standard development. And we have a lot of specifics on that. On the next slide, our third strategy, our convene strategy. Here we identified our responsibility to spotlight health equity related topics through all of our forums, all of the forums that are available to us at HPC as an essential way to apply an equity lens. So a specific example is the annual cost trends hearing, which we were really successful at doing last year. Health equity was the focus. We highlighted issues of inequity, issues of justice, especially with our keynote speaker, Dr. David Williams, and particularly given the impact, the disparate impact of the COVID-19 pandemic had on communities of color. It was really timely, so we will continue that. And then finally, for the watchdog strategy on the next slide, please. Understanding how market changes in the distribution of healthcare resources impact certain populations is really important, or how they may perpetuate inequities is also a key area of focus in the watchdog strategy. So more to come on that. And then on the next slide, a little bit about accountability and our internal action plan. We shared this with you at the July 2020 board meeting. We've made a great deal of progress on all of these items over the past year. So some have already been implemented, some will continue on an ongoing basis, others are underway, others are currently in progress. So in addition to this, to dedicating time in our public meetings to focus on health equity topics, providing ongoing updates to you, our Board of Commissioners on this work, we're implementing several ways to gain input internally with our staff from all levels, which are listed at the bottom of the slide. And I won't go through them, but the most important are, obviously continual review of our progress against our objectives and goals, and also just want to highlight continuing to push hard on our internal diversity, equity, inclusion efforts as a workplace and as a culture, which we've been really leaning into as we've been a remote. So I'm not going to talk about it today, but we're also developing a tool to be able to track our progress. It's a new internal health equity initiatives dashboard. So more to come on that at a future meeting. And then on the last slide here, but very much not least slide, earlier this year, I shared with you that staff had created an internal tool to support colleagues when communicating about equity. So several of you, our Board of Commissioners, have reviewed this and weighed in, and we really appreciate that. The Health Equity Practice and Style Guide is intended to be a practical resource to promote intentional and consistent use of language and terminology across the agency and across all of our work products, and to encourage reflection among staff as we consider equity in all of our work streams. So what eventually became an agency-wide effort actually began really organically as a collaboration between staff from our investment programs and staff from our research teams. They reflected on equity-related topics frequently covered in our work, as well as questions from previous work products that they felt were unanswered. And they just found they needed a practical resource that would be used by the entire agency. In development, we did consult external resources. It's highly sourced and referenced. We received input from across the agency. We did have town halls on this health equity style guide before we rolled it out. And as I said, board members, advisory council members on both the structure and the content areas. So the resulting guide has been rolled out internally and is currently in use by all of our teams. And I think I would just add, it's really a living document. It's a collaborative document. We've dedicated staff from each team to a special team who are committed to continuing research on these topics of interest and providing support to agency colleagues, because really when you use the guide, you often do have more questions than answers. So it really is a tool. We are committed to updating it. We're committed to republishing on a regular basis. We also recognize in all humility that this is not exhaustive. We're researching other areas to include, such as language related to mental health and substance use disorders, weight, rural populations, etc. So it will be ongoing and will be updated regularly. So we have received so much interest and wonderful feedback on this effort. So I'm really excited to announce that the Health Equity Practice and Style Guide is now available for the public on our Health Equity webpage on our website. So please do check it out. Please do share it. It's our dream that it could be of use to anyone else, but it's really an internal resource that we wanted to make public. So thank you so much to Aisha Anderson and so many others on staff who worked on this. I really wish I could shout all of you out by name, but that's it from me. I'm happy to take any questions, any feedback that you have. Mr. Chairman, back to you, and back to you, Dr. Seltz.
Mr. Chairman, I think you're still on mute.
Yeah, excuse me. I'm trying to keep things moving, but Colleen, I want to thank you for taking us through this. It's an important part of our activities, and I want to check whether there are any questions or comments of our commissioners before we move on. Again, I know we're going to be hearing a lot more about this as we move forward. So thank you again, Colleen, and I'll turn it back to David.
Great. Thank you, Colleen, and thank you, Mr. Chairman. So moving along in our agenda, I'm going to turn it over now to our Director of Market Oversight and Transparency, Kate Scarborough-Mills, who will give our regular update on market changes.
Great. Thank you, David. To start us off, we have our standard slide showing the material change notices we've received to date. So since 2013, when we began tracking, the Health Policy Commission has received notice of 127 different provider transactions, with formations of contracting entities continuing to be the most frequent, followed by physician alignments, and then changes in hospital affiliations and clinical affiliations. On the next slide, you'll see that we currently have 2 material change notices under review, which were received since our last board meeting. First, the proposed affiliation of Joslin Diabetes Center, including its Joslin Clinic facility by Beth Israel Lahey Health, BILH. Joslin, as folks may know, has a long-standing relationship with Beth Israel Deaconess Medical Center, and Joslin physicians currently participate in payer contracts through the BILH contracting network. The parties state that the transaction will provide Joslin with research investments, create operating cost efficiencies, and provide opportunities to expand collaboration between Joslin, BIDMIC, and BILH. Next, we received notice of a proposed acquisition of Walden Behavioral Care by Montanito Corporate Holdings. It is an eating disorder treatment and psychiatric care provider with residential, inpatient, and outpatient facilities in Massachusetts, as well as locations in Connecticut and Georgia. Montanito is a national eating disorder treatment provider with programs in many states throughout the country, and the parties state that they do not expect any changes in the services provided by Walden. We will obviously update you on our findings as that review proceeds. Finally, even though it isn't a material change notice, you'll see here that we've also listed our review of the 3 interrelated determination of need applications by Mass General Brigham in anticipation of providing a comment on those applications to the determination of need program in the coming months. We will have some brief updates on the DON review process in a couple slides. But before we go to that, I see a question.
Yes, Kate, thank you. My question with regards to Walden, are both of these organizations for profit? Do you happen to know?
Off the top of my head, I am not sure, but we will certainly incorporate that into our review process.
Okay, thank you. I get concerned when I see nonprofits being taken over by for-profit. We have a rich nonprofit history here. I worry about losing it. Thank you.
Understood. Great. So since our last board meeting, we've also elected not to proceed to a full cost and market impact review on 2 transactions that you see listed here. First, a proposed clinical affiliation between Boston Children's Hospital and Cape Cod Hospital, under which Children's and its affiliated physicians would provide 24/7 in-house professional medical services, clinical oversight, and medical leadership to Cape Cod's pediatric program, as well as certain wraparound services. In our preliminary review, we found that while there is a meaningful difference in the price between Cape Cod and Children's, the volume of pediatric services is quite small, meaning that the overall scope of spending increase is likely to be small even with that price differential. And if Cape Cod is able to retain some pediatric care that would otherwise go into Boston, that's likely to result in some limited cost savings. We did not review evidence indicating that the transaction is likely to negatively impact clinical quality or access to care. Second, we elected not to proceed to a full cost of market impact review on a clinical affiliation between South Shore Health System and Aspire Health Alliance, formerly known as South Shore Mental Health. Under the proposed affiliation, the parties would jointly collaborate on the planning, development, and implementation of integrated behavioral health clinical programs for the benefit of residents in their respective service areas, with the goal of ensuring that patients receive appropriate behavioral health care. In our review, we found limited scope for spending impacts due to the transaction. The transaction would not affect contracting practices and therefore is not expected to impact prices or market concentration. And while the parties' integrated behavioral health plans have the potential to reduce spending and improve quality and access, I will say that the plans are not at this stage sufficiently well developed for us to assess whether and to what degree quality or access may improve. But at the very least, it's unlikely that quality or access will be negatively impacted. And then we can go back to talking about the MGB determination of need application. So as I teed up a moment ago, we wanted to provide a brief process update. So as a reminder, providers are required to submit an application to the state's determination of need program within the Department of Public Health before they can make specific changes in their operations, including major capital expenditures. And the HPC is a party of record to that process, meaning that we get copies of all filings and we have the ability to provide comment to the determination of need program to assist in their review. Back in January, Mass General Brigham filed 3 interrelated determination of need applications with a total cost of $2.3 billion. You see those outlined here. So the first was a major expansion, renovation, and improvement of Mass General Hospital, including the construction of a new building with a total of 94 new licensed beds, 24 new operating rooms, 7 new advanced imaging units, among other things. Second, there is a DON application for a major expansion, renovation, and improvement of Brigham and Women's Faulkner Hospital, including the construction of a 5-story addition, which also includes a number of new medical surgical beds, observation beds, expanded endoscopy, a new imaging unit, as well as shell space for future build out. And finally, the creation of 3 new ambulatory sites in Westboro, Westwood, and Woburn, which would be alongside a new site in Salem, New Hampshire that isn't subject to the Massachusetts determination of need review process. Each of these 4 sites is expected to include clinic space, an ambulatory surgery center, advanced imaging, as well as a number of other things. On the next slide, you'll see that the major update here is that part of the DON process is an opportunity for the public to provide comment on applications and for interested parties to register as parties of record by forming what are known as 10 taxpayer groups. There has been a very high volume of public input on these applications. Because of a technical issue during the initial period of public comment, DPH opened a second period for written comment on the ambulatory sites applications, but now all periods for comment have now closed. And in total, DPH received over 1,000 written comments on the applications, primarily on the proposed ambulatory sites. The comments came from a wide variety of parties, as you see listed here, and those comments are now posted online and on the websites for each DON application. As always, DPH will consider the comments when assessing the application's compliance with the DON factors, but wanted to let you know that HPC staff are also closely reviewing all of those comments. Finally, on this last slide, as we've discussed, the Department of Public Health may, at its discretion, require that an independent cost analysis, or ICA, be conducted for any determination of need application to demonstrate that the project is consistent with the Commonwealth's healthcare cost containment goals. An ICA, the independent cost analysis, is conducted by an outside consultant who is approved by DPH, but is done at the expense of the applicant. As you may recall, DPH has required an ICA for all 3 of these determination of need applications, and it is our understanding that the ICA on those 3 applications is now underway. This means that the entire timeline of the DON review is now paused until the ICA or ICAs are completed and accepted by the determination of need program. There is an opportunity after an ICA is accepted by the Department of Public Health for parties of record, including the HPC, to provide comment. So it is currently our plan to provide comment during that 30-day window. Staff are already working on the analytics that will support the comment, considering a range of potential impacts on the proposed projects on utilization, market functioning, overall spending, and health equity. And we look forward to providing you updates on those substantive findings in the coming months. Pause there for any questions.
Yeah, thanks, Kate. Commissioners, are there any questions or comments so far about what Kate has indicated was going on? I'm sure we all look very eagerly to the report on the potential implications of this substantial increase in spending. So any Yes, Don, please.
Yeah, Stuart, thank you. Thanks, Kate. Kate, it procedurally, when our comments are created, when you the drafts that you're now working on, what is the role of the full commission in review of and approval of those comments? Or are we not part of that process?
Our expectation would certainly be to provide a lot of information and opportunities for commissioners to provide feedback on that before it is issued. I will note that the timeline is relatively quick, but we will strive to ensure that all commissioners are heard through the process. And that is something that is formally submitted. I believe when we have done this in the past, it came as a letter from Chair Altman. So it isn't the level of formality of, say, a cost and market impact review report, but we have chosen to have commissioners really have a very active role in that in the past.
Will that include a vote? Does the commission vote on the approval of the comments?
Yes, in the past, we did vote in our previous comment for the children's transaction, and we anticipate a vote here.
So let me understand, since we have there's this 30-day window,
That's
which has already begun or is about to begin?
No, it's a 30-day window after the independent cost analysis is fully complete and has gone through the review process at the Department of Public Health to determine that it is done and acceptable. And
so it's very likely that we will have a full commission meeting during that process, which will allow us to discuss it and vote. Is that correct?
That is our expectation.
Very good.
Stuart, this is Mary Lou Sutters. It's also the HPC, and Lois, you can correct me if I'm wrong, but the HPC weighs in prior to the Public Health Council reviewing and deciding on the application as part of the HPC being a member of record. And somewhere there's a really good slide if people need to be reminded of what the process is that the staff might want to send out again.
Yes, that's correct. We anticipate that our comment will be prior to any Public Health Council vote.
Well, it's more than just expect. That's the process.
Yes. Correct.
Exactly, and that apologies, that timeline was fleshed out, I believe, at the April board meeting. So those should be as part of the April board meeting slides, but we are happy to circulate them after the meeting.
Let's see, David Cutler.
I think some of this discussion picked up on what I have, which was, do we want to think about scheduling a meeting of the commission in between the report and the 30 days, towards the end of that 30 days? And if we know when the report comes in, we could, we might need to schedule that in advance.
Well, we have to wait for the report from the consultant, right, Kate?
That's correct, and there is not a fixed timeline for
That's
that.
right. So,
but if we find out that's going to come in, September 27th, then we know that the 30 days starts ticking then.
yeah, but yeah, so we want to wait for we have to wait for that report, and B, we will, it would be very helpful to have that report before we have a discussion. And C, we want to have that discussion and our comments as was stated before the council itself rules. So yeah, we'll make sure that we have a meeting that meets all those standards. Other questions or comments? All right, well, thank you, Kate. Is there anything else you want to say?
No, that was it for our updates. I will turn it back to
All right,
David.
then I'm going to turn it back to David to introduce the next information.
Great, thank you. And thank you, Kate. So next, we're going to shift gears a little bit and wanted to share set of key findings from our data points release, which we expect to release today, on dental emergency department use. And so to walk through some of our key findings on this new research blog, I'm going to turn it over to Diana Sanchez, who is the research associate who led this work.
Great, thank you so much, and good afternoon, commissioners. I'm going to be sharing with you the key highlights from the 20th issue of the HPC DataPoints, Oral Health, Access, and Equity in the Commonwealth. So just for some background, access to high quality and affordable oral health care continues to be a challenge for many Massachusetts residents. And when residents lack access to oral health care, they may turn to the emergency department, or ED, for care that could have been prevented or treated in a dental office. The HPC has published prior findings related to preventable oral health emergency department visits, with a policy brief in 2016 that found that a substantial number of ED visits in Massachusetts are for preventable oral health conditions, and the first ever issue of the HPC DataPoints in 2017, which identified 33,400 ED visits for oral health conditions in 2015, with variation by region, age, and income. And this 20th data points builds on these prior publications and looks particularly at ED visits for non-traumatic dental conditions, using an algorithm developed by the Association of State and Territorial Dental Directors. This methodology differs from that used in these prior publications, with the benefit that it was compiled by oral health experts. And for reference, non-traumatic dental conditions includes caries, periodontal disease, erosion, cysts, impacted teeth, and other non-traumatic conditions that are associated with the oral cavity. Next slide. So in this data point, we look particularly at ED visits for non-traumatic dental conditions between 2017 and 2019. And the HPC found that in this period of time, these ED visits decreased by 12.5%, which is a higher decline than the decline in overall ED visits for this period of time of 1.4%. And most of this decrease was due to fewer visits for caries, periodontal disease, or associated preventive procedures, which is abbreviated as CPP on this graph. Next slide. And now looking at ED visits for non-traumatic dental conditions by age, the HPC found that residents between ages 25 and 34 had the highest rate of ED visits for non-traumatic dental conditions, experiencing 8.9 visits per 1,000 population in 2019. And overall, we see that those residents between ages 20 and 54 had higher rates of these visits overall when compared to other age groups. And although there were decreases in ED visits for non-traumatic dental conditions from 2017 to 2019 for all residents, it's worth noting that Black residents still experienced 2.7 times more ED visits for non-traumatic dental conditions than white residents in 2019. And as you can see here, Black, Hispanic, and other race residents had a higher rate in 2019 of ED visits for non-traumatic dental conditions when compared to the overall rate for all residents, as indicated by the gray dashed line. And as our last highlight, the HPC saw that in 2019, 65% of ED visits for non-traumatic dental conditions were by Massachusetts residents in the lowest two community income quintiles. It's worth noting here the strong gradient by income, and in addition that in 2019, those in the lowest community income quintile remained far above those residents in other community income quintiles in terms of number of ED visits for non-traumatic dental conditions. Next slide. And so For our conclusions, the HPC's research shows that these ED visits for non-traumatic dental conditions vary by race and ethnicity, age, income, region, and payer type, suggesting disparities in access to preventive care and treatment for dental conditions. And we know that avoidance of routine dental care due to lack of coverage, access, or affordability can have long-term health consequences, both mental and physical. And as stated by prior oral health publications and policy recommendations, the HPC continues to recommend that the Commonwealth authorize mid-level dental therapists to practice as an equity-centered intervention to expand oral health care access, with additional policy opportunities, including ED referral programs and teledentistry innovations. So thank you so much for your attention. We encourage you to look at the data points when it's published on the HPC website, and happy to answer any questions.
That was great, Diana. Thank you so much. Are there any questions or comments by my fellow commissioners? Don?
Thank you, Stuart. Diana, that's spectacular work and something we've looked at repeatedly. I'd like to ask about item 3, which is an area of particular interest to me. I've written and done research on this, whether we have reiterated or should reiterate our support for this important innovation, which has worked in many other states and the Commonwealth has still held back a bit on. Second, I wonder, David Seltz, I could just bookmark this one, is maybe a little session on this at our cost trends hearings would be worth it as a follow-up to our equity work of last year. This is a pretty dramatic set of findings. Thank you.
Thank you, Commissioner. I was just to quickly respond. In this data points, we do include text that reiterates the recommendation, the policy recommendation around the dental therapy program. This has been also filed as legislation before the legislature. And Governor Baker has filed this as part of his healthcare pieces of legislation as well. So continue to hope and support the legislature as they consider establishing this, and do agree that there is very sound evidence that these can really expand access for populations in need.
Stuart?
Yes, please.
So just a point of reference, in the Baker-Polito administration, we have completely now restored the oral health benefits in the Medicaid program that had been eliminated in prior administrations. So on adults, in the FY21 budget was the last piece of the restoration of oral health adult dental benefits in the Medicaid program in Massachusetts. It's taken us a while to get to, but those are in place. And in June, we announced a $100 million commitment to our federally qualified health centers, which includes a 65% increase in rates for oral health care. So I appreciate, and having actually worked on the issue of dental therapists when I was outside of state government, it obviously can be quite effective as ensuring or expanding access to folks who don't. So I think this is one that we should continue to explore. But I'm a little surprised that the data brief doesn't include the things that are happening in the Commonwealth.
Oh, that's great.
Well, a little overdue.
Yeah, well, that's right. Patty, you wanted to say something?
Yeah, I think this is one of those issues that flies under the radar. And I was just wondering, we were quantifying number of visits and the decline in those. But do we have the dollar amount associated with those visits?
We do not. No, not in this data points. We just report on number of visits and rate of ED visits.
Okay. It'd be interesting to see what we quantify that in terms of, dollar amounts and potential care avoidance in the future. I think it would be an interesting data point to have.
Thank you, Commissioner. I agree. And I just absolutely agree with that comment. And that's certainly a place where we can take this analysis moving forward. The brief does include some national estimates of how much this costs, and it is quite significant on a national basis. And so we could think about how we could model that for Massachusetts specifically. And just wanted to also, commend and recognize the administration's work on a number of these dental policy investments and policies. And we'll make sure that we are referencing those appropriately in the brief.
Yeah, and unfortunately, I just might add, from the commercial perspective, with employer groups with robust dental coverage, it's amazing how often people do not take advantage of their routine care and may end up as one of these emergency room patients just because they didn't go and take care of their teeth when coverage was provided in full. So it's not always a lack of coverage. It's a lack of getting to the dentist.
Well, let me strongly put myself in support of all of the comments. And I do think it's important that we include the whole dental area in our cost trends discussion. From a personal level, even though I had good coverage and went to the dentist religiously at the right time, my problems with dental care did have a significant impact on my acute care, clinical care as well. So even on a personal level, even with so-called good coverage, although the dental coverage is rarely as good as the coverage for acute, we tend to separate them when in fact I think they ought to be treated more similarly in terms of benefits. So yes, David Seltz, let's make sure that dental sort of reaches a level that's commensurate with its potential impact.
It may also be helpful to look at some of the stats related to other states that have implemented similar policies that we're looking at and see what some of those results are.
Absolutely. Great idea, Ron. Any other comments? Diana, you did a great job, and you can see the interest among commissioners. And it's good to hear that the state has moved aggressively to put that back. Didn't know it was taken away in the first place. Wow. All right, I'm going to turn the program back to David Seltz to.
So Stuart.
Yes, please.
One of the, and I know Don knows this well. Unfortunately, oral health and dental benefits in the Medicaid program are considered optional benefits and not a core benefit of the Medicaid program.
Yeah, it's symptomatic of how we've treated dental.
So, as is mental health.
Yeah.
So.
You're right. Thank you. Okay, David, we will come back to this subject.
So thank you, commissioners, for those comments, and thank you, Diana. Wonderful job. So we're going to shift now to the 2021 cost trends reports. And so on the next slide, you can see here that we have been presenting the findings from the report over the spring and early summer at a number of the HPC meetings, and at this point have largely presented most, if not all, of the really key findings from the report. And so for today, we really want to shift to begin the conversation with commissioners around policy recommendations for inclusion in the final version of the report. As I said at the outset, this is a first conversation. We do have some draft recommendations for commissioners to react to, but this is really hopefully an opportunity for a conversation and discussion. And then over the course of the next 2 months, we will meet with commissioners to finalize the final report and the recommendations to be voted on by the full board for final release at our September board meeting. So before we dive into the policy recommendations conversation, however, I do want to just turn it back over to David Auerbach so that he can just provide a high overview of some of the really key findings from the cost trends report as a reminder of and to ground the board discussion in some of the data that's in the report. So we'll first just walk through some key findings from the report, and then we can begin the conversation on the recommendations. So with that, David, what did we find in this year's report?
Great, thank you. Yeah, I will just run through some of the highlights from the presentations we've given over the last few months, as you saw on that previous slide. We found some interesting things as always, and not entirely unexpected. So reviewing where we've been with respect to the benchmark, we were over in 2017-18 and in 2018-19 based on the preliminary data. Okay, next slide. And the major contributors to that growth in the past 2 years have been hospital outpatient spending, as you can see, 7.6% growth in 2018-19, as well as physician spending and hospital inpatient spending. And we just note again at the bottom that hospital spending accounted for more than half of the growth from 2018 to 19, even though it's not more than half of the total cost or the total spending. And as we break down the spending trends into prices and utilization, we continue to find that it's more prices than utilization, about twice as much. And that's what the payers report. That's what we see from third parties such as the Healthcare Cost Institute running the data on Massachusetts. And our price chart pack, which we presented at the MOAT meeting, some of the highlights there were that price growth in the hospital inpatient sector, and this is commercial, was 9% over the 2 years, 2016 to 18, 6.1% on average for hospital outpatient, and 4.4% for physician office services. That's growth over the 2-year period. And this Loch Ness Monster graph here, again, reminding you that nationally, hospital prices in the commercial sector really spiked towards the end of 2020 and 2021, over 6.2% year-over-year growth. And we have seen some indicators that could be happening here in Massachusetts as well. And if that's true, we could be in for very high spending growth in 2021 and beyond as utilization returns to normal levels or even higher. Okay. And especially with regard to hospital outpatient spending, it's not just prices, but in a sense, a component of price growth is if services shift from lower cost or lower price providers to higher price providers. Now, overall, SHIA finds that the concentration of spending in the highest price hospitals has grown. In 2017, 51% of hospital spending was in the highest price quarter of hospitals. That went up to 54% in 2019, so more concentration in the high price hospitals. And the graph below shows that happening with regard to hospital outpatient visits. You see a tick up in the number of those that are occurring in AMCs from 2018 to 2019. And then on the next slide, the implication of that, when you have volume shifting like that, that exacerbates the growth in spending if you have price variation. And we have price variation. We've known that for a long time. And again, this is summarizing hospital outpatient prices by hospital. And you see several, far more than even double what Medicare would pay. Next slide. And another view of that, just looking at a standard colonoscopy service, more than 2-to-1 variation in price. And this slide is emphasizing the fact that for a lot of services that could take place in a physician's office or a hospital outpatient department, the amount being paid to that hospital outpatient department is often double or more. And as volume shifts in that direction, we're paying more. Now, putting all of this together, I'll then talk a little bit about just summarizing our findings on what does this mean for affordability for the average Massachusetts resident. How are we paying for this care? And the answer is it's becoming more and more difficult. I'd like to just show the long run premium trend to remind us that in 2000, family premiums for commercial insurance in Massachusetts were a little over $7,000, about a third the price of a new compact car. And now those premiums have gone higher than the car, tripled in about 19 years to more than $21,000 per year for family health insurance. And we find an increase in the proportion of middle-class families who are paying more than a quarter of all earnings going to healthcare. It's about a third between 2016 and 2018. It used to be 28%. So this is taking a bigger and bigger bite out of what families have to spend. And on the next slide, also showing that the previous slide was really just focused on premiums. That's not even counting what people pay out of pocket. And the amount people pay out of pocket is critical for a number of reasons. It's money out of their pockets. And as we'll see, it leads to avoidance of care. This is showing a CHIA slide of the trend in high deductible plans. You can see an increase 28%, 31, 35% by 2019. And more than 2/3 of all small group insurance is a high deductible plan. And that high out-of-pocket spending we showed, and we will show in the cost trends report, and you saw some of this, leads about 1/3 of people with lower income and with commercial insurance to avoid care because of cost. And they're avoiding all kinds of care, specialist, prescription, mental health care, much more likely to do so than higher income folks. Next slide. Particularly true if you are in a high deductible plan, which we've shown are increasing in prevalence. You're about twice as likely to go without care because of cost. And in addition to, next slide, avoiding care because of cost, people also we found were avoiding care because they weren't sure that it would be covered when they're considering an episode of care. And they have good reason to be unsure about that. There are surprise bills, there are unexpected bills, and people find their benefits very complex to follow, which is completely true. We all find that as well. Okay, next slide. The consequences of that uncertainty, the high costs, along with going without care because of cost, leads to things like potentially avoidable ED visits. And we see that terrible combination in that top left quadrant where 2/3 of people who went without care because of cost and have low income said their last ED visit could have been avoided. And you just have some of the consequences of avoidance of care and unaffordability of care coming into a terrible storm. Okay, so that's a review of what we saw. Back to you, David.
Great. Thank you for that quick run through of some of the key findings of the report. So switching gears now to begin the conversation around potential policy recommendations. I first wanted to pause and just highlight a framework that we have been thinking about with regards to both the findings of the 2021 cost trends reports and the experience of the COVID-19 pandemic, just further highlighting the interrelationship between healthcare costs, affordability, and health equity. And as David mentioned, as we struggle to contain healthcare costs, those have real implications for the affordability of care for residents of the Commonwealth. And with some, including communities of color, bearing even more of these costs, leading to further inequities. And all of these impacts then have the effect of further increasing overall costs. And so without being able to control costs, you can envision a vicious cycle between these three boxes of cost, lack of cost containment, leading to affordability challenges, contributing to further inequities and avoidance of care that leads to unmet healthcare needs that then further drives up total healthcare spending. And so as we were thinking about a framework for policy recommendations this year, we thought about how do we change this vicious cycle into a virtuous cycle? How do we change it so that the gains that we make on cost containment are really also serving our goals on affordability and equity? And so as I walk through a set of potential policy recommendations, wanted to highlight this framing. On the next slide, just to highlight again, we have 10 draft recommendations to walk through today for your reaction and feedback and comment. And again, are interrelated between the different recommendations on these issues of cost containment, affordability, and equity. As always, the potential recommendations include some new ideas as well as revised and refreshed recommendations from past cost trends reports that continue to be topics of priority and interest for the Commission. So as I said, the final policy recommendations will be included in the report in September. So at this point, I'd love to just walk through some of the draft recommendations that we have put together for your reaction and feedback, and also for your comments on, are there additional topics that we should be considering or working on, or are other ideas that should be on the table for inclusion in this year's report. So there are 10 of them. So I think my plan was to kind of walk through 5 initially, and then pause for some conversation, and then walk through the final 5, as there are a lot here. So the first recommendation, a potential recommendation, is around enhancing the Commonwealth's healthcare accountability framework. As is noted before, the Commonwealth has exceeded the healthcare cost growth benchmark for 2 years in a row, and in the last year exceeded it quite significantly. And so in light of this spending growth, we're suggesting that the Commonwealth should strengthen mechanisms to hold healthcare entities responsible for spending growth. In particular, we think there are opportunities to improve the annual performance plan process by allowing CHIA to use metrics other than health status adjusted TME to identify entities with concerning growth in spending. By using other measures besides HSA TME, we can expand the scope of providers beyond just primary care groups that could be referred to the HPC for review, and also address the impact of medical coding, which can mask spending increases with the health status adjustment. We also think there may be opportunities to enhance the PIPS process even further by strengthening financial penalties for above benchmark spending or for non-compliance. I would note that other benchmark states or states that have adopted healthcare cost growth benchmarks have considered ways to strengthen their benchmark, and Oregon is actually pursuing a policy where there would be financial penalties for entities that were had above benchmark spending. The second sub-recommendation here is to complement and bolster the healthcare cost growth benchmark by the Commonwealth setting measurable goals that target affordability of care for consumers, and also that seek to advance health equity. And the measurement strategy here would identify and track improvement on those metrics with the goal of really being able to ensure that the Commonwealth is moving forward and advancing on the 3 goals of cost containment, affordability, and equity in tandem and supporting each other. On the next slide is our second recommendation, which gets to some of the ways we think that we can strengthen the Commonwealth's efforts to contain healthcare costs. So as David mentioned, prices continue to be the primary driver of healthcare spending growth in Massachusetts. And the shift in care from lower priced providers to higher priced providers is a key reason why we failed to meet the benchmark in recent years. And as David noted, the variation in hospital pricing has not diminished since the establishment of the healthcare cost growth benchmark. So here we think there are opportunities to more directly address high price growth by considering perhaps provider caps on very high pricing, as well as restraining price growth over time. By focusing such policies on the highest price hospitals, this would have the additional impact of improving equity as more revenue and reimbursement would be shifted to lower priced providers, as well as to really encourage competition on value rather than strategies that seek to increase market share or raise pricing. The third recommendation on the next slide seeks to recognize the growing trend that we have seen in ambulatory and outpatient care. And so, as David mentioned, hospital outpatient was one of the key drivers of spending in the most recent year, both in terms of utilization, price, and the shift in care to higher price providers. And so here we suggest that the Commonwealth should continue to really expand our focus on outpatient care and improve data collection so that we can better monitor and understand how care is shifting in these settings, both between hospital main campus and off main campus, from physician office to hospital outpatient, all of which may have impacts on cost, quality, and access. And then the second sub recommendation here is a repeat of ones that we have made many times in the past, which is that we do think that there is an opportunity for the Commonwealth to really help contain unnecessary costs by limiting facility fees. Facility fees, as David mentioned, can more than double the cost of care that's provided at a hospital outpatient setting that otherwise maybe could be treated in a physician office. Oftentimes, patients have no idea that they are being treated in a hospital outpatient setting versus a physician's office. And there are opportunities to build off policies that MedPAC and others have considered to implement and require site-neutral payment for common types of office visits so that no matter where patients go, they're getting the lower reimbursement for those services commensurate with the costs. On the fourth recommendation, we have noted and continue to note that recent increases in patient risk scores and acuity and believe these may be explained better by changes in payer and provider documentation and coding behavior than by changes in actual patient health. And so we think there is more to be learned and to research in this area and perhaps actions that could be taken to mitigate the impact of clinical documentation on spending and performance measurement. And then finally, for the first five, we would continue to make a recommendation. Again, this is a repeat recommendation around the Commonwealth's taking action to moderate drug spending growth and improve affordability for patients. In particular, we continue to support the proposals of Governor Polito and Secretary Suthers, which would expand the current successful program of the HPC's Drug Reviewing Authority to include drugs that have a financial impact on the commercial market, as well as to increase oversight of PBMs and the pharmacy distribution chain. So I will, I think maybe let's return back to the first recommendation, and I will pause there and happy to take comments, questions on any of these first five.
David, and to my fellow commissioners, I think the five areas that David laid out are extremely important. I mean, I'm just repeating what you've already seen. I think we're facing, the most serious pressure on healthcare costs that we've experienced in the 8 years that we've been in business. And I'm particularly concerned about that rapid rise in prices that David Auerbach indicated. I'm very pleased that David Seltz has focused broadly on a whole variety of areas, whether it's a price caps on the highest increases, the concern about the growing inequities in terms of some institutions getting big increases and others having inadequate funding, the whole issue of physician for pharmaceuticals. So thank you, David, for laying these out. And I welcome any comments or suggestions by my fellow commissioners. Anybody want to jump in?
Professor Cutler?
So I want to support some of the things that Stuart and David were just saying in the following sense. I think when this legislation was enacted, my understanding of the arrangement was that everyone agreed we should lower spending. The state decided that the private sector argued that they could with appropriate incentives do that. And therefore they didn't need heavy-handed regulation. And the state said, fine, we won't do heavy-handed regulation, we'll do monitoring. And as long as you can meet those targets, then the monitoring will be fine. And that happened for a few years. And my sense is that what's happened in the past couple of years is that the provider community in particular saying, oh, we're just being monitored, so it's not such a big deal. And it's become a game, like how do you beat the HPC, stay within whatever you need to stay in, but you beat the HPC in the state. And that to me strikes me as violating the rules of the game and violating the rules that the state implicitly agreed to with the private sector. So if that's the response of the private sector, which is, oh, it's a game and we're going to find our way around it, then the state, I think, needs to go back and say, no, if that's the way you want to do it, we're going to have a more regulatory perspective on this. And we're going to do either limitations on prices, or we're going to do the following sorts of things. But I don't think we can let this continue. It strikes me that this is trying to find ways around the law that they agreed that was purposely weaker than it might have been, because that's what folks agreed they could do. And now if they're going to take back that agreement, fine, let's go to whatever the alternatives were on the table. So, and there may be alternatives that we have through performance improvement plans, there may be other alternatives at the state level, but I just think this can't continue. And I think we're in a position where we have to say this can't continue.
Thank you, David. You articulated my concerns very well. Don Berwick?
Yeah, I join you, Stuart and David, in that. I think that comprehensive finding that the current regime is failing to control costs in the state of the Commonwealth is a finding we should be very explicit about. And I think what David's suggesting, which is there are no consequences yet for that failure, and unless the legislature chooses to create consequences, I don't predict the future will be much better, much different from the past. I have two other quick points, Stuart. One is procedural. I think this extremely rich set of potential recommendations, and we've only looked at half of them so far, call for extensive commentary and discussion from us commissioners, as commissioners. And I think, is there a process through which we can have input outside the public meeting? I don't need to have an opportunity to have private input. I'm happy to make the input public, but I'd like it to be more considered than we can fit into the time available today. This is great start. The second is there is a couple of edgy ideas under number one, David, that I want to just talk about. One is, I think the same thing you did under recommendation number two, which is to rarely recommend that the focus of this accountability should be on the higher cost providers, not the higher increase providers. The higher cost providers is an important change in our approach that I think should be made explicit. I sometimes am concerned that for middle and low cost providers, they face the same benchmark. And although we say it doesn't need to apply across the board, we do that. And I think I would urge you to strengthen that element of this and the second recommendation. We need to focus on those high costs, which means the study of variation, which has somehow become a bit muted in our work in the past couple of years. I would encourage us to re-energize the variation in price studies. A final small comment on this, and then I'll shut up, which is, I think it might be better to separate affordability targets and equity targets. I think they each deserve attention, and I would have a B and a C instead of lumping them together, because we've got equity problems even if we were affordable. We've got affordability problems even if we were equitable. Thank you.
Thank you, Commissioner. I'll just speak quickly to the procedural question. Absolutely, we expect to engage all commissioners in the drafting of these set of recommendations over the next 2 months for a board vote with the final report in September. So expect to have that opportunity. And I will just to let you behind the curtain a little bit here, Commissioner Berwick, agree with you on separating B into B and C, and candidly just ran out of space on this slide. And so nonetheless, the sentiment is in agreement.
Tim Foley?
Thank you. And I typically try not to piggyback and add to what's been said and second everything that has been said, but I thought it's really important to weigh in as well, particularly what Commissioner Berwick just laid out on input into this. Is a lot to take in a short amount of time that we have to do it. I think it's great to see new recommendations. I think there's been a number of areas in the last couple of years. It's been the same type of recommendations, although important as they are. I'd like, these are bold recommendations that's responsive to what the data is suggesting where we're headed. And I think to the former speakers here, I really do think separating out not all growth is the same in this market, and really taking that into consideration, and how particular the cap that is referenced and the increased penalties for the PIP work together. I think it's going to be really important to figure out. And so I just want to second all the comments that were said before me. I typically try not to do that because there's a lot of important voices to hear, but I think they're really important to reinforce and continue the conversation. Look forward to engaging in this because I think the first 5 are really bold and significant and are responsive. And again, that not all growth is the same in these markets. And I think in particular, separate from that, I think this affordability standards and setting a goal and a benchmark for that is incredibly important. I think, again, responsive to what we're seeing in the market, and we have to hold ourselves accountable to where the impact of these costs are being borne, and that's on lower wage workers and residents of the Commonwealth. So I appreciate the first 5 and look forward to the next 5 and further conversations about all of it.
Anyone else want to jump in? These are very helpful. I do want to put in context what I think has gone on. First of all, I give the Commonwealth and the individuals who put together the legislation, both in the legislature and in the governor's office and who else, that Massachusetts led the curve in several important areas. One, I think most importantly, is we have by far the best database, which allows us to look, as David Auerbach was able to do, than any other state. And we can only build on that, but we don't want to lose sight of that, and we surely want to make it even better. And the second area is that unlike other states, the Commonwealth focused on total spending, not just on what government is spending. And I think that's become increasingly important as we've seen private insurance rates grow by leaps and bounds, so that total spending, which after all affects the affordability that David Sells mentioned, and particularly impacts negatively, not only on our lower income people, but also the middle class, if not the upper middle class. So the idea that the original legislation focuses on total spending should not be lost, but I do want to ultimately strongly support David Cutler's history lesson, which is, I think we did a good job. No, I wouldn't say we. I think the whole system did a good job in the early years following the passage of 224 in 2012, but that the game is now getting tougher. And what we're recommending is that the process also needs to get tougher.
Stuart, if I may.
Yes, please.
So one, there's going to be 10 recommendations. I just want to echo a little bit of what Don said. So I think that these are all meaty. There's no way we can do all 10. And I do think it merits both individual conversations with the staff, as well as I think robust discussion among the board members before it comes to us for a vote. Because the compression of the individual comments and then the staff doing an extraordinary job, I'm sure, of consolidating comments and the like, and then we have a consolidated conversation and vote. So that's a process thing. Secondly, on 1A, we actually have this written. The administration, actually in the governor's 96-page healthcare bill, which seems like a lifetime ago, actually did exactly that. We propose strengthening the accountability for spending growth in excess of the benchmark. And so I think I won't be quite as cynical as maybe some of my colleagues, but when you write legislation, it was very good legislation when it happened, right? We're at a different place in time. And it is the time for us to think about that. I just want to give one little, it's a nuance on a recommendation on another page. And it has to do with facility fees. I just want to like plant this, because one of the principles we made on telehealth was and particularly telebehavioral health, we felt it was very important to pay parity rates. One was to telegraph the importance of telehealth, right? And that wasn't a lesser kind of service. The complexity is when we think about parity of in-person and telehealth, does that include facility fees? So the law as it's currently written, one would suggest is if I'm doing parity, I'm paying parity including facility fees. And so I would just do a little caveat to that recommendation. If we're looking at facility fees, it also needs to take a slightly, there's a nuance to this. I see David Seltz nodding his head, but as someone who's trying to implement it right now, it's a little bit of a flummox. That's my nice word for it.
Thank you. David, why don't you give us the remaining 5, although you've given us so much to think about already.
Sure, and thank you, Secretary Sutters, and I would agree to the process steps that you've laid out, and we'll work with you and the commissioners to make sure that all voices and considerations are included here, including what are the topics and the exact language here. This is what we're showing on these slides is in some ways a streamlined version of what could be a larger recommendation with the nuance that you suggest. So the last 5 here. So number 6 is really around continuing to champion and support the efforts of the administration on emphasizing and addressing social determinants of health and other drivers of health equity. This has been a recommendation we have made in the past. I think one of the enhancements we're suggesting here is really around state agencies all working together with the stakeholders around the appropriate data collection that will allow us to really integrate equity considerations more fully into our work. And that work is already ongoing. Many state agencies are already working on that, as well as really suggesting that providers should focus on equity impacts when they're considering expansions or care delivery changes or other market changes, and that they should demonstrate how those changes will address inequities rather than perpetuate them. On the next slide, we have another recommendation on focusing on primary care and behavioral health care. So this is also a little bit of a repeat recommendation supporting one of the major tenets of the governor and Secretary Sutter's healthcare bill around increasing the proportion of spending for primary care and behavioral health care. There continues to be very considerable evidence that healthcare systems that are oriented towards primary care have lower costs, have higher quality. And there's an opportunity to shift some of the growth in spending while still keeping below the benchmark to primary care and to behavioral health care. The next recommendation, 2 recommendations on this slide, again, topics that we have spoken about before. The first is continuing to understand that administrative complexity in our healthcare system adds additional costs, complexity, harms patients in many ways, and that there are opportunities for the Commonwealth, along with health plans, providers, and patient groups to identify ways to standardize or reduce unnecessary administrative complexity. On number 9 here, we have, again, have research in this cost trends report that shows that Massachusetts residents receive a significant amount of care that does not provide value, and that the provision of that care really varies depending on what provider or physician or provider system you go to. And so I think, as has been suggested at past meetings, here too, we see an opportunity perhaps for some convening with payers, providers, and purchasers to discuss strategies and incentives to eliminate or reduce low value care. And then finally, while the Health Policy Commission is charged with a much bigger report on the impact of COVID-19 and evaluating some of the innovations that occurred during the COVID-19 pandemic, wanted to suggest a recommendation here that at least begins to hint at some of those areas where we believe the Commonwealth should take steps to sustain innovations that were made during the pandemic. Some of these have already been sustained, as Secretary Sutters mentioned, around telehealth. There has been an extension of some of those provisions, but would note here too, under workforce flexibilities, a recently released report by the Health Policy Commission recommending that Massachusetts join the Nurse Licensure Compact, and that there are other workforce flexibilities that should continue to be sustained. Providers were working on innovative care models that moved care out of the hospital and into the home and community, which should continue to be studied. And finally, we've seen more of a willingness by providers to think about accepting primary care capitation or other value-based payment models after the pandemic. And those may be areas that we want to continue to examine and encourage and advance. So those are the 10 recommendations. I'll pause here again to see if there are further comments on the last 5.
Well, again, I want to thank you, David, because I think you've used the next 5 to sort of broaden out into these areas that often go under the radar. Are there comments or questions from my fellow commissioners?
Could I just ask a question? David, would it overload this process to include a section on the prior, like last year's recommendations, or look back, and then a kind of audit of any responses or progress that's been made? Have they been taken seriously? Who's acted on them? What's new? I think you've done so much here. I hesitate to put more on the plate, but that would be interesting to see.
I think there is a way that we can incorporate that. And I would note that there have been some recommendations that we made in last year's report that were advanced as part of the healthcare legislation that passed at the beginning of the year. One in particular that has been a long time recommendation of the Health Policy Commission is removing outdated scope of practice restrictions on nurse practitioners. And so that was included in the healthcare bill. And so that was one recommendation that we've had, and certainly there are others that action has been taken on that we could catalog.
Other questions or comments? Again, this is extreme. I can't emphasize enough how important these 10 recommendations are, and the need for further discussion on our part, working, putting together the report, working with the administration and with the various committees to see to what extent we can get some of these implemented. Because as David Auerbach pointed out, we're very likely to see the biggest increases in spending and prices during this fiscal year, if not into the future. So I've given you all another minute or two if you have any questions. If not, we will come back to this, obviously, in the future meetings. So let me turn the program back to you, David.
Great, and thank you. And as you said, Mr. Chairman, much more to come here. So we have one final piece of business of the HPC to conduct today. So as you all know, the state fiscal year runs from July 1st to June 30th every year. And as part of that fiscal process, the state establishes a state budget. That state budget does include an appropriation for the Health Policy Commission for the operations of the HPC. Just last Friday, the conference committee of the House and the Senate advanced their budget proposal to the governor for review and action. However, that process is not yet complete. It is under active review, but we do not yet know what the final budget number for the HPC will be. So today I'm asking for a vote of a continuing resolution that would allow the HPC to continue to operate at the level of funding that was in fiscal 2021 until such time as we come back and approve a final operating budget for the next fiscal year. That would be something that we would add to the agenda for our September board meeting for that approval of the next year's budget. So really just an extension of our budget capabilities and operations until such time as the budget is finalized and we can return with a vote of the full board. So this is a motion and a vote. And Chair Altman, I don't know if you want to reflect that the Administration and Finance Committee.
So we had a pretty detailed discussion about this motion and did get into a little of the detail about how the money has been spent and will be spent. So the Administration and Finance Committee of the board unanimously supports this recommendation, that we have this continuing resolution to continue spending at the old rate, and then we will have a more detailed breakdown review by first the committee and then the full board following the passage of the budget. So I will accept a second for the motion.
So moved.
All right. Again, we need to have a roll call of approval of the budget. And again, I'm going to turn to my friend and savior here on the roll call, Colleen Alsamaya.
Yes, starting with you, Mr. Chairman.
I approve.
Great. Vice Chair Cohen.
Aye.
Commissioner Berwick.
Aye.
Commissioner Blakeney.
Aye.
Commissioner Cutler.
Approve.
Commissioner Foley.
Aye.
Commissioner Haupt.
Aye.
Commissioner Master Giovanni.
Approve.
Madam Secretary.
Yes, I approve.
Thank you. And finally, Brendan Moss, please.
Aye.
Thank you.
Okay. Very good. Okay, so
we have one more vote, Mr. Chairman, just to
Yes.
enter into executive session and then we can adjourn.
that's right. So we need to take an official vote to move into executive session. So again, Colleen, you will read the roll call and
Absolutely.
and then if it's all right with everyone, we will take a 5-minute biological or whatever break. But please come back as quickly as you can. So let me turn it back to you, Colleen.
Sure. As you all well know by now, the process to enter into an executive session requires a roll call vote by the board. So we'll ask for a motion. If we can put up that vote language too.
So moved.
And a second.
Second.
All right. And I will commence with a roll call, Mr. Chairman.
Okay, approved.
Vice Chair Cohen.
Aye.
Commissioner Berwick.
Aye.
Commissioner Blakeney.
Aye.
Commissioner Cutler.
Aye.
Commissioner Foley.
Aye.
Commissioner Haupt.
Aye.
Commissioner Master Giovanni.
Aye.
Madam Secretary.
Aye.
And Brendan Moss.
Aye.
Thank you so much. And with that, we're ready to adjourn, Mr. Chairman. Our next board meeting currently is scheduled for September 15th of 2021.
Very good. I want to thank everyone for really an important meeting. And so let's take a 5-minute break and then we will meet in executive session.
On the same Zoom. Don't disconnect from the Zoom.
No, don't disconnect. The whole world will collapse if you do that, Don.